All right, terrific. Welcome, everyone. My name is Chris Visco. I'm welcoming you to our rehabilitation webinar that we have now, an ongoing monthly webinar. We are in our second official installment, and I'm very excited to welcome you all here to join us for this discussion and really an ongoing dialogue about health, well-being, rehabilitation, regeneration, and all things that matter to the human body. We are excited to get into it today to talk about plantar fasciitis. Plantar fasciitis is a hot topic, something that comes up in a variety of ways in both athletes and non-athletes alike, and we have some terrific speakers with us today. This is really a joint effort between Columbia, Cornell, New York Presbyterian, and the Department of Rehabilitation, and as well as Brooklyn Methodist, and our speakers are come to us from all of our sites. So we've got Dr. Colleen Brough, who's an assistant professor and director of clinical education for the programs in physical therapy. She is a founding director of Columbia Run Lab at Columbia University Irving Medical Center. Dr. Brough, as well as Dr. Siddiqui, are two people that I've worked with very closely, both clinically and outside of the clinical realm in a variety of academic pursuits. But I'm very excited to welcome them both. Dr. Siddiqui, who will be speaking second, is the Chief of Rehabilitation Medicine at New York Presbyterian Brooklyn Methodist Hospital. He's also an assistant professor of rehabilitation while Cornell Medicine in the Department of Rehabilitation. Really two experts on not only just plantar fasciitis, but really all aspects of the musculoskeletal and neurologic system, and true experts in sports medicine. So I want to get directly to their talks, and I would like to stop sharing my screen so that Dr. Brough may share her screen and then go ahead and begin her talk.
Sure. Just give me one moment and I'll get going on that. It's great to be here with you tonight, Dr. Visco, and thanks for everybody who is tuning in virtually. Here we go. Can you see my slide?
Yes, we can see it fine.
Okay, great. And thankfully, after 3 years on Zoom, I am not muted and ready to go. So I'm Colleen Brough. I've been a physical therapist for over 20 years. And like Dr. Visco said, I'm the founding director of Columbia Run Lab, which is a running analysis experience for runners of all levels, where I see many patients, runners, people who present with plantar fasciitis. So let's get to it. I'm pleased to be here tonight. I have no disclosures and I have no financial gain. So the plantar fascia is a thick band of connective tissue that connects the calcaneus, or the heel bone, to the toes. And plantar fasciitis is characterized by micro tears of that structure. Sometimes that can be associated with inflammation, and the name certainly suggests that it is an inflammatory process, but primarily it's degenerative. And these patients typically complain of pain with palpation or pressing on the proximal insertion of the plantar fascia, which is right about here. It's really tender, and that pain is exacerbated by weight-bearing activity, and it often occurs. Patients will describe that it occurs when they first take those initial steps after a period of inactivity. So if you, particularly in the morning when you first wake up, that can be a hallmark sign that you're dealing with plantar fasciitis. When we consider the evidence of who's at higher risk for getting plantar fasciitis, that includes folks with higher body mass indexes, especially in non-athletic populations, patients who present with limited ankle dorsiflexion, that's the ability to move the foot up in this way, patients with calcaneal bone spurs. That's been closely associated with the presence of plantar fasciitis. Runners, they are at a higher incidence of getting plantar fasciitis, as well as those individuals who have work-related activities where prolonged standing is part of that. So all of these folks are at higher risk of developing the heel pain known as plantar fasciitis. And I put this little little comment in association is not causation. It's important for us to keep in mind that we can't say that heel spurs, for example, cause plantar fasciitis. Instead, these are factors that seem to be associated with developing it. So how many people are we actually talking about that get plantar fasciitis? Is it 10,000, 50,000, 150,000, or a million annually? Rapid fire in the chat. I'd be curious to see what your guess is. You have 5 seconds to drop something in the chat.
A million.
10. You think it's 10, 50,000, 150,000 patients presenting annually, or a million?
A million. A million.
So somebody already knows the answer. Yes, it's a million. It's a million physician visits that occur because of plantar fasciitis alone, if you can believe that. So among athletes, this condition is especially prevalent. Upwards of 20% of all runners experience plantar fasciitis at some point. And the really challenging thing about this condition is that it'll start with pain that's mild, with intense activities, for example, but then it often the course of this experience is that it devolves into pain with simply walking community distances and standing. Fortunately, the good news is that about 80% of patients who have plantar fasciitis typically report resolution of symptoms within a 12-month period. So in preparing for this particular talk, I was curious to see what's the latest and greatest in terms of the evidence. And interestingly, there's been an explosion of research into plantar fasciitis over the past 5 years, with multiple systematic reviews, meta-analyses, and clinical practice guidelines that have emerged to try to help guide us as to how to manage this issue. And my takeaway from my PubMed black hole into the literature is this. You know what this is? This is the kitchen sink, because that's what we clinicians tend to throw at this condition, because there doesn't seem to be one simple cure-all. This particular sink, Glacier Bay, can be found at Home Depot for $119. But seriously, we in fact throw every possible modality that we can think of at plantar fasciitis generally, because there's nothing super strong in terms of the evidence that is extremely well supported. I'm going to highlight some of the things that we want to be sure to include, like there's moderate evidentiary support for taping. So we use anti-pronation taping, for example, for immediate and early pain reduction. Elastic therapeutic tape like K-tape, or rock tape on the gastrocnemius and the plantar fascia can be helpful. Night splints are popular very early on. Look at this archaic thing that you wear at night. It's called a Strasbourg sock. It's really uncomfortable, but it helps keep that plantar fascia on stretch. Heel cups are really popular. Here is a Hoka rocker bottom sneaker in a lovely acai color. Rotating your shoes is commonly prescribed, and I often tell my patients to not go barefoot at any time. So you want to have a supported longitudinal medial arch. That's sort of the inside arch of the foot. And in regular shoes, I will have folks add a little heel cup to take some of the pressure and strain off of that plantar fascia. And then orthotics can be helpful. There's moderate evidentiary support for a custom-made orthosis. If you go to physical therapy, manual therapy is well supported. And specifically, that's meant to improve ankle function and foot mobility. So here we're looking at, talocrural posterior glides, and all of the joints in the foot there can be stiffness that presents and limits the mechanics and how the foot is working. I will say that my favorite quote that I read in the literature this week was this one. There is lack of evidence for the dogma of clinical and mechanical measures of foot and ankle function for plantar fasciitis, Van Leeuwen et al. 2016. That means that we don't yet really understand where the data points are leading us. we are, in my opinion, we haven't found the right lens through which we need to look at plantar fasciitis. And one thing that was interesting is that activity limitation and participation restriction, meaning telling patients to just rest and stop all activity, despite the discomfort that it might cause. Actually, we in fact grade such things. It received an F on an A to F scale. So that was really discouraged. But whenever I encounter a condition that takes sort of a kitchen sink approach, I remind myself that research only reveals one side of evidence-based practice. There are two other parts. One is clinician expertise, and the other is patient report. Which means that in my experience, what really works in managing plantar fasciitis is a tailored and individualized approach to managing each of my patients who have it. So two critical elements that I feel like are often overlooked that I wanted to highlight are mechanics, right? So do we move in ways that are efficient? Can we better optimize the alignment when we move and weight bear? So that's one. And then the other is, if we can't change our alignment or mechanics in weight bearing because of morphology, as in that's just how we're built, can we increase our tolerance and capacity to endure force and load? So let's take a quick look at that. When it comes to improving mechanics in the lower extremity, we've got to start with hip and core strength.
Interestingly,
I think someone needs to be muted. If somebody on the admin side could help me out with that, I would be grateful. So we look at hip and core strength. My top choice for hip and core strength is the standing fire hydrant exercise. Here is a former graduate of our Columbia program, Ein Bowie, who's dominating West Coast running at Run Resiliently. She's demonstrating the fire hydrant exercise. And you see in one fluid motion, the leg is coming out to the side on the diagonal, all while maintaining good alignment at the pelvis, knee, and hip. And that's really where we want to focus to maintain good alignment as you are developing hip and core strength. And then secondly, you've got to have adequate ankle mobility and flexibility of the gastroc. Both must be present in order to have normal mechanics, whether you're walking or running. And that is especially true for the medial gastroc muscle, where stiffness here was correlated with plantar fasciitis. So maintaining good alignment with the knee over the toe as she leans in and keeps the heel down, we're getting good bone movement, right? So movement of that talocrural joint, and we're getting a nice stretch of that gastroc muscle. To increase the intensity, we can add a weight. Here you see a kettlebell, and you can put the foot up on a step. And to increase the intensity even further, you can have it on an uneven surface like this. So this is going to improve ankle dorsiflexion mobility. Both of these elements will help with mechanics. Next, and I think in my experience, this is an area that typically is neglected. We need to increase our capacity to tolerate force and load. And in order to do that, I love me a good deadlift or a goblet squat. Whatever your preferred method is, what we tend to do is we tend to lean on this 3 sets of 10 idea and medium level weights. In fact, and Dr. Siddiqui is going to highlight from a histological perspective why it's so critical to incorporate heavy loads. We need to increase our lower extremity lifting, and to do so with heavy loads. Doing so has been shown to decrease lower extremity injuries in runners by up to 50%, which I found particularly compelling. And here's the real key. In my opinion, I saved the best for last: eccentric heel drops. This most directly is impactful on managing my patients with plantar fasciitis. These are called loaded eccentric heel drops. And one of the challenges with plantar fasciitis is that the tissue, the fascia itself, after a prolonged period of time becomes disorganized. And heavy loading eccentrically is one of the best ways that you can normalize that disorganized collagen within the fascia. So meaning the muscle is going to lengthen as it contracts. So here you can see we start in an elevated position with both legs. You put all the weight on one side and slowly lower down, thereby contracting the gastroc, the soleus in a lengthened way. And then you return back up with both feet. And the progression for this is to do it weighted. Any kind of weighted eccentric heel drops that you can do, whether you're at the gym and you simply are in a seated position and you place a heavy plate, a 50 or 100-pound plate on your lap, you really need to increase the load on that plantar fascia and on those gastrocs. These are my references. And I am glad to turn it over to Dr. Siddiqui.
Thank you so much, Dr. Bruff. Again, if someone has questions, you can go ahead and enter them into the chat box, and we'll also take questions at the end. But for now, we'll go directly over to Dr. Siddiqui.
Thanks so much. Can you guys hear me okay?
We can hear you.
All right, great. And that was such a fantastic overview of really a very complex topic in the sense that, plantar fasciitis is a very unique clinical condition. It's a condition in which the tissue itself, we're trying to really optimize a tissue that is not in and of itself active or contractile or doing much, but rather responding to the load that's placed on it by all of the surrounding structures and really the body as a whole. And so in taking that into account, there's just a little bit about me. I'm a sports medicine physician working at Cornell and at New York Presbyterian Brooklyn Methodist Hospital. As we sort of start to understand what the plantar fascia is trying to accommodate, it really becomes very important to understand what type of tissue it is. So when we kind of look at this anatomically, and I don't mean to gross anybody out with these lovely images, but the plantar fascia is a very fibrous, non-contractile, meaning it's more similar to a ligament than to a tendon structure that connects to or originates from the heel bone, primarily on the inner aspect towards the midline. It has a very narrow origin and it fans out in sort of a triangular shape, separating into 5 different bundles that then attach to the tendons of the toe flexors. And so that takes this seemingly static tissue, which doesn't in and of itself do much, and gives it a dynamic component that it has to adapt to with the action of the toe flexors. And it crosses actually a number of joints as it integrates with the toe flexors. It crosses not just the joints of the midfoot, but the joints of the toes in a way that makes it a big contributor to the stability of the arch of the foot. And so when you're walking or when you're running, you are going to be activating this in a very cyclical, repetitive manner. Through this mechanism, this is an example of what's known as the windlass mechanism, where because this plantar fascia is not all that stretchy, as the toes flex to accommodate the various phases of gait, the plantar fascia is put under tension. And as a result, because this tissue is not all that stretchy in and of itself, it induces a change in the alignment of the foot and becomes a very important stabilizer of the arch in these positions. So this is something to think about as we think about movement, gait, and why this pain has the particular pain pattern that it has. So when we zoom in a little bit more, we can see that the tissue itself, for a tissue that is not contractile or not active in that way, it is a fairly dynamic tissue in that there are different zones of the plantar fascia where different tissue types are interacting with each other. So at this origin, you have an area where the fibrous tissue of the plantar fascia itself connects and interdigitates with a fibrocartilaginous plate, which is basically sort of a cartilage bridge or link to the bone of the heel or the calcaneus, and that serves as one anchor point of this structure. At this area close to the origin of the plantar fascia, we also see that it's not just collagen, which is sort of the mainstay tensile tissue that makes up ligaments, tendons, that sort of thing. There's also, if we look here, if you can see my mouse, where these yellow arrows are, there are also chondrocytes, little islands of chondrocytes, which are the progenitor cells of cartilage that exist within the bands of the fibrous tissue and the collagen. So these chondrocytes are load responsive through this mechanism that we call mechanotransduction. These chondrocytes are going to feel and experience the strain and load that's put on the tissue, and then respond by forming new cartilage, which can occasionally ossify into new bone. As we sort of zoom into what the tissue looks like in the fascia itself, we can see that this is a fairly organized structure when it's in its native healthy state, and you have these beautiful bands of collagen that are tightly packed and provide that. When they're densely packed like that, they provide that tensile strength. It's almost like a bundle of spaghetti. If you try to break a bundle of spaghetti, it can be very difficult. But as cumulative load occurs throughout time and activity, you get little areas of fissuring, little areas of cracking, and areas where where that nicely packed tissue develops scarring and swelling, which then affects the mechanical properties. And we see this reflected in what we see in our various imaging modalities as we're trying to get to the bottom of where a particular heel pain is coming from. On X-rays, we might see a little heel spur, as Dr. Brough talked about. These heel spurs tend to be more associated with the presence of plantar fasciitis and not necessarily causative. People can get very concerned when they see heel spurs or see that on an X-ray report. We know that while this can certainly predispose to irritation, inflammation, and can be reflective of the type of loading that might result in plantar fasciitis, the heel spur in and of itself is not the problem and doesn't necessarily need to be addressed. When we advance into modes of imaging that can help us actually see the plantar fascia itself, such as ultrasound, which is what's here on the top, and MRI, which is what's here on the bottom, we can actually kind of compare side to side. Here on the left, this is an example of what a normal plantar fascia would look like, where you have this band right here in the middle of the screen, which is fairly uniform in thickness and attaches nicely to this calcaneal surface. This bright white line right here is the heel bone. When you compare that to what's here on the right side, where you have a much thicker origin of the plantar fascia with darker signal, which reflects sort of the disorganized nature of the collagen fibers in this area, which kind of tapers into your more normal thickness of the plantar fascia as you move through the foot. Again, this is reflective of that mechanism of repetitive strain and injury causing micro damage, which then accumulates in the tissue and affects the mechanical properties. And on the MRI, we can see the same thing. We can see thickening of the origin of the plantar fascia. We can see a little bit of associated bone edema from the stress, and all of these things can point to potential areas of intervention. But as we mentioned, the plantar fascia does not exist in and of itself. It is a part of what we call the posterior chain, and that is the full sort of interrelated musculature that allows us to be upright human beings and propel forward. And so all of these structures, these are all muscles, but all of these structures play a role in loading the plantar fascia and how you accommodate the load of the plantar fascia. And we can see that even in histological studies, where we can see that the connection between the plantar fascia doesn't just attach to the bone. There's actually fibers which wrap around the heel bone and connect to the peritoneum of the Achilles tendon. And so load on the Achilles tendon, which is a more dynamic structure because it's directly connected to the calf muscle, is experienced by the plantar fascia. So we got to think about this thing more holistically in terms of the kinetic chain, and particularly as it affects our activities, we really need to be thinking about not just what's happening at the foot, but what's happening, top to bottom. And so when we kind of look at things from a more holistic perspective and look at how gait affects multiple joints, you don't need to understand these kind of force diagrams to recognize that in areas where there are greater ranges of motion of the joints, those areas or those phases of the gait cycle where there's more joint motion, you can see almost that an alignment between the ankle, the knee, the hip, and the pelvis. Even if the type of motion is not the same, the motion at one joint is felt at the other joints and is responded to at the other joints almost in real time. And so with the foot having all these kind of complex and compounded axes of motion, what we see is that the gait pattern really plays a role in how the foot experiences pressure, and that's why certain activities may affect certain people. And if you've seen one case of plantar fasciitis, you've probably seen one case of plantar fasciitis. You really have to individualize your assessment as you would individualize the treatment. But as we can see, in our runners, this is an example of where the force is experienced through the foot in someone who lands with their heel, someone who lands with their midfoot, and someone who lands with their forefoot. And someone who lands with their heel is going to be putting a lot more direct compressive force on that plantar fascia origin, whereas someone who lands on their forefoot is going to be putting a lot more tensile strain on that plantar fascia. And so the pain pattern and the response to the load is going to be somewhat different. And as we kind of think about this from the perspective of the ground reaction force, as we're looking at running gaits, you can see that in folks who tend to run on their toes, there tends to be a much more sort of upright ground reaction force with the point of contact being closer to the midline. Or to the center of gravity. And as a result, the load that the plantar fascia will experience is going to be tensile. On the in our heel strikers, you can see that plantar fascia is not being stretched; it's being directly pounded. So it's this lever mechanism that really applies a very amplified load to the plantar fascia and induces a lot of these structural and functional changes that we're experiencing. And so, I'm not going to try to out physical therapy, Dr. Bruff, but these are certainly, some of the modalities that we see on the physical therapy side, and it's important to have someone who understands the science behind what they're doing, and it's not employing these therapies as a matter of rote. As you can see, there is a method to the madness, and so if we, as we try to communicate that becomes very important for having good outcomes. Gait retraining, I found can be extremely helpful, and that's where having a tool like the Run Lab can be extremely beneficial, because making a lot of these changes can be difficult if you don't have some feedback. If you don't have whether it's visual or some sort of tactile feedback that you can respond to, but generally, for a lot of these lower extremity overuse type syndromes, what we see is that increased cadence, shortened stride length, decreased contact time, and running with a more steady posture, limiting the amount of up and down that you're actually doing. Tend to be helpful, but again, this has to be a much more individualized intervention. And then when all that fails, that's sort of when you're entering into a physician's office, and this is where we might employ things like short periods of immobilization with a boot to kind of break that cycle of pain causing dysfunction, causing more pain, and then the concept of load management becomes very important, because we know that within the first week of immobilization you start to see atrophy of connective tissue and soft tissue structures, and so the goal is not to put someone in a boot and let them just be in that boot for a number of weeks. The goal is to kind of use that period of time to calm things down, and then very load responsive and pain responsive way gradually increase their activity slowly and steadily. And the use of medications, injections, really, at that point, what we're trying to do is either modulate in both an anti or pro-inflammatory way, really depending on what you're trying to do. The mainstay of treatment for a long period of time has been a short course of anti-inflammatory medications. And what we've learned is that, that may, while it may help in the short term, it may not be the best thing in the long term, but there is still a role for those interventions to allow people to be functional. On the injection side, traditionally, corticosteroid or steroid injections, cortisone injections, whatever you might call them, have been employed for this condition. There are some risks associated with steroid injections in terms of what they do and how they might weaken the plantar fascia itself and put you at risk for a rupture. That is a real risk. It's rare, but it is a real risk. And so these should be employed thoughtfully and with image guidance. There are other injection options that are more biologic, that have a different philosophy behind them, with the goal of trying to sort of change that inflammatory and load responsive environment. Those would include things like platelet-rich plasma, where what we're trying to do is actually reignite a stalled healing process, and then use physical therapy and a more corrective loading paradigm to get a better outcome. And then finally, there are, this is the step right before surgery, would be something like a percutaneous needle tenotomy, where basically we're actually using the needle, either a large gauge needle, or there are some devices that are on the market that do this in a much more dramatic fashion, where they sort of irrigate and debride. But we're really trying to sort of break up that scar tissue that has made its way into the space between the healthy tissue, by trying to break that up, we're trying to sort of debulk the area of pathologic tendon, and then again try to use that period of reignited healing response to get to a better outcome with load management and physical therapy. But again, we have to address this in a continuum, and that's why it's very, it's very useful to have partners of different disciplines, because this is truly an interdisciplinary problem, and the best outcomes are, interdisciplinary approaches.
Well, thanks so much, Dr. Siddiqui and Dr. Bruff. I think we've got tons of questions coming in from the chat here. I had a couple questions as well. I want to maybe just consolidate a couple of these concepts. We have a lot of questions coming in about kinetic chain stuff. So about gait, the posterior kinetic chain. Can you show the perfect gait? Like, what is the ideal gait? There must be an ideal gait, right? Right, Dr. Bruff? Isn't there like the perfect running mechanic or the perfect gait?
There is. And, I saw that early in the chat, and I grabbed a slide for whenever we're ready to turn toward that one. I'm glad to,
go for it.
Share that comparison. Sure. So
while Dr. Bruff is getting that loaded up, the next question after we talk about the gait is going to go to Dr. Siddiqui about more advanced procedures like PRP and all this. Like, when do you do that? So you think about that, Dr. Siddiqui. That's going to go to you next.
So here you can see what Dr. Siddiqui was highlighting, right? So a sort of non-optimized mechanics or non-optimized gait is where we're seeing the foot placement land very far forward from the center of mass, a very straight knee, right? And a very high, what's called contact angle, where when that foot hits the ground, the toe is really pointed up. And that creates a hard braking force and increases the strain and stress across that plantar fascia. When we compare a non-injured runner to an injured runner, what we see is that here's a better one. What we see is that the placement of that foot is much closer to our center of mass. Like if I drop a plumb line straight down from center of mass, that heel lands very near the body. There's good knee flexion, which is about 20 degrees, right? And then as you load onto that leg, it's at about 40 degrees. And you compare that to this knee here, which is very straight. You can see this toe is pointed straight up towards the ceiling. If I made an angle with the bottom of the sneaker and the treadmill, it's pretty high. Whereas this sneaker lands practically flat. And so this is more ideal insofar as it decreases the load across that plantar fascia tissue, but it also creates more of a spring. There's more of a spring and there's more give, whereas here we're hitting pretty hard with every step.
Well, that makes some good sense. Loading up that, high contact angle, straight knee, increases the force across that plantar fascia and all the structures of the kinetic chain all the way up. And so, when we have a situation that's not responding to the desired treatments, as Dr. Bruff and Dr. Siddiqui laid out, Dr. Siddiqui, when do we escalate care? When do you go to things like more advanced procedures? When do you escalate to even surgical things? What about the PRP too? Can you talk about that?
For me, that's certainly much more a functional question than it is a radiographic or radiologic question, because similar to a number of other degenerative adaptations that you'll find in the body, bulging discs, rotator cuff tendonitis, or tendinopathy rather, those are things that we may see on imaging, but may not actually be interfering with your ability to function. And so it's when it gets to the point of interfering with your ability to function, and you've tried some of these, load management type activities where if you notice that you're skipping your weekend basketball game or skipping your nightly tennis, or you're finding that you used to maybe walk to work and now you don't want to do that because you know you're going to pay for it later. Those are the points at which seeking some kind of evaluation is probably beneficial, because while you don't necessarily need to escalate it too early, you certainly don't want to wait until it's further down the line and now you're deconditioned and now you're not experiencing some of the downstream effects. And again, I think some people feel that I've had people come into my office and almost apologize because they're like, oh, it's just heel pain. It doesn't really, you probably see much more serious things than this. And my response to that is always, if it's interfering with your function, it's serious enough for me to take it serious, because it shouldn't be. And so that's where, trying to lay out the full menu of options, everything from short period of rest to a surgical debridement, you see that's a very large spectrum. The evaluation is really to see where you fall on that spectrum, and you may and to kind of take you to where you need to be.
Understood. So about the PRP thing that came up.
Yeah. So very specifically about PRP, I am typically going to that in chronic cases that have typically failed a course of physical therapy, and I hate using that term, but have not responded to a good course of exercise-based physical therapy.
Does that include steroids? What about steroid injections? Do you have to have a steroid injection first? Or?
Oftentimes, I will have people who have had steroid injections, and we do have to be mindful of that in terms of proximity, because steroids and PRP, they're choosing different lanes in terms of what you're trying to accomplish. I will in my practice, I will often do a steroid injection probably more frequently than I do PRP, not because of my preference or because I think it's what's best. There are other factors with PRP that factor into patients being able to do that. Unfortunately, PRP is not a covered service by insurance, and so that can be prohibitive for people. But usually they will have attempted a course of immobilization, a course of physical therapy, plus or minus, definitely a course of anti-inflammatory medications, and possibly a steroid injection before we actually go to PRP.
Got it. Thank you. Dr. Bruff. Not everybody's a runner. That's here. And of course you have the run lab and you've identified ways to alter running mechanics. But what about just everyday walkers or just people that want to be active and plantar fascia is affecting them, or they want to protect their feet? And then second part of that question is, I'm in need of new shoes, new sneakers. What should I get? And is there a specific recommendation? Should I go get something to prevent plantar fasciitis now that I've watched this talk? Is there something that's going to save me from that?
Great questions. So let's start with the sneakers first. Look, there has been some support of rocker bottom footwear, which in my opinion helps minimize the strain on that plantar fascia. And anecdotally, many patients have reported that they find greater comfort with that. And so, that's certainly a good go-to move. The Hoka shoes are an example of those, but there are many rocker bottoms. Skechers has a nice rocker bottom if you don't want that kind of really thick last, or the bottom of the sneaker tends to be thick with the Hokas. And then in terms of the first part, the truth is that many of the patients that I see or have seen were not runners who had plantar fasciitis. And, then we're not trying to necessarily change their running gait. But I would argue that the similar like pillars of treatment apply, where we need to minimize the amount of strain on that plantar fascia. So I want them in shoes as soon as they wake up. They need some sort of house shoes. what works really well for those are and I'm forgetting the name of them, it's just escaping me. They're sort of like hippie sandals, can't think of them, but you get the idea because they're really firm and they're sort of, they give,
Birkenstocks.
what are they called?
Birkenstocks.
Birkenstocks. So the Birkenstocks are fantastic for that, for sort of walking around in the house, because they give that medial longitudinal arch support, meaning you don't want the foot to go into excessive pronation. Not that I'm saying that as an absolute, but there has been some evidence that demonstrates excessive pronation has been correlated with increased incidence of plantar fasciitis. And anecdotally, patients report that they feel better if they're not walking barefoot. And so in my experience, it's really the everyday small little details that they need to attend to on the physical therapy side, right? So it's if you're wearing a shoe, wear something with a little bit of a heel if you can. If you can't, you put a heel cup in, and that's just going to minimize the strain on that plantar fascia. And it's going to, in fact, act as a little bit of a shock absorber right at that insertional pain that patients typically get. Icing can be really comfortable. I've heard of some folks having a positive result with something called A-stim or deep tissue massage to that plantar fascia. Any of these modalities are acceptable. And then I would say add in some eccentric heel drops and really try to load that tissue.
Terrific. This is really outstanding. We have far exceeded our allotted time of 30 minutes, and we have many questions coming in. I think we could probably have a whole nother session on just the questions. We're going back to, is there evidence for plantar fascia in prehistoric times, and so forth, which I love and appreciate these thoughtful questions, and I'm appreciative of both of your expertise in coming to the table with the content. But what I think what we should just do is leave on maybe a final point. We have a lot of folks here who have individual stories, and that's what we're seeing coming through the chat. I'm a dancer. I have to use orthotics. I've done this and that. I've tried an injection. What should I do next? And I think that a lot of folks are looking for answers. What would you both recommend to folks? So in two ways. One is, if they are starting to feel plantar fasciitis, what is the number one very first thing that they should do? And then two is, if they're seeking additional advice or care, what do you think is the right next step for them to escalate it, since we have a lot of individual stories here of folks in the audience?
I'll say from my perspective, for folks who are able to and don't have medical issues that prevent them from taking over-the-counter analgesic medications like Tylenol or naproxen, maybe a 1-week course of taking something like that a little bit more regularly, accompanied by some activity modification and trying to figure out what it is exactly that's triggering the pain. And then from there, it's a bit of watch and wait for a short period of time. But if I'm still finding that my folks are not able to get back to their normal activities after maybe 2 weeks of making those modifications, I don't think you can go wrong physical therapy first versus physician first. I think on its initial presentation, you can certainly get benefit from going both ways, and then you escalate from there. But a prompt evaluation when you notice that those basic home modifications are not making a difference, that's what I would recommend.
I'd like to give a shout out to Dr. Siddiqui for using mechanotransduction. Did you know that has 19 letters in that word? So I was really blown away by that. And my answer to that question is sort of, what's the first line of defense or attack? when someone comes for conservative management of plantar fasciitis, it's really, pain management through footwear and activity modification. If you can eliminate it early, you'll be better off than having to deal with it on the back end. And then secondly, and maybe this is the most important thing, is I think you heard from both of us that a tailored, individualized approach is really essential. And it underscores Dr. Siddiqui's eloquently described spectrum of the treatment options for this condition. And so I would suggest really being with somebody that you trust. For example, when patients are not tolerating or are not progressing in the way that I expect, I feel very, very thankful that I have rehabilitation MDs that I can turn to and say, this patient isn't responding well to PT. Can you examine this patient? I think we need to take it sort of to that next step. And so having that exchange and really understanding the scope of that spectrum of care is really invaluable.
Well, Dr. Bruff, Dr. Siddiqui, really thank you many times over for contributing your expertise on this important topic of plantar fasciitis. To all those in the audience, thank you for attending today, and the Department of Rehabilitation at Cornell and Columbia, thank you for hosting. We are so glad to have you, and looking forward to having you again. We're having a session on rotator cuff coming up on October 11th. Please join us for that. It should be an engaging and thoroughly fun topic. We will also be sending out a survey post this meeting, and if it does come out and you happen to be one of the folks that gets it, please take the time to fill it out. And we're looking for some audience feedback as we go and tailor this to meet your needs as well. Should you have a need to make an appointment or you need to reach out to one of our campuses for any reason, there are phone numbers available to go ahead and do that. Once again, thank you. Have a great day, everyone.